is about to equal 120 millimeter of mercury. So to maintain the forward flow and prevent the reversal of flow, the valve opens and closes in response to the pressure difference between the cardiac chambers, like LV and aortic valve. So when there is abnormal valve function, there appears the stenosis, means the closure or blockage, or the regurgitation, which is also called insufficiency or incompetence. When there is stenosis, any valve is stenosed, then there is obstruction to the valve flow during the phase of the cardiac cycle when valve is normally open. The hemodynamic hallmark is pressure gradient, means there is a pressure difference. Like अगर जैसे अभी हमने LV और aortic valve के हमने जो pressures देखे थे, तो there is a difference between the LV pressures and the aortic valve pressures, aortic pressures. So in regurgitation or insufficiency, there is inadequate valve closure. Means in that there is, so a single valve can be both stenotic and regurgitant, but both lesion cannot be severe. Like agar valve stenosis is moderate, then regurgitation is severe, or if stenosis is severe, then regurgitation is moderate. If it is happening in the same valve. So the combination of the valve lesion can coexist, like because of the single disease processes. As an example, like if there is a rheumatic pathology, then there is mitral stenosis and aortic stenosis as well. So two valves, maybe tricuspid valve involved. So this can be extended up to more than one valve. There may be different disease processes, like if there is MS, but there is VSD, it is causing aortic valve insufficiency. And one valve lesion may cause another, like there is a severe AR. Agar severe AR hota hai, it hits continuously over the mitral valve and cause disease again, and it again cause the mitral regurgitation as well. But there are some combination of particularly burdensome like AS and MR. So, what is the etiology? When there is aortic stenosis, it may be because of degenerative calcific. Like in old age, the aortic valve become degenerative, stenotic. Other cause may be congenital, or it may be unique. Congenital may be unicuspid or bicuspid. There is a rheumatic pathology, rheumatic heart disease, and prostatic aortic valve. When there is aortic insufficiency, there is in fact it may be due to infective endocarditis and acute aortic dissection. And acute aortic dissection may be due to Marfan syndrome or any chest trauma. Now we are coming to the aortic regurgitation or aortic insufficiency. The aortic leaflet, if it is because of aortic leaflet disease, it may be due to infective endocarditis, maybe rheumatic, bicuspid aortic valve, prolapse or congenital VSD, and prostatic aortic valve. There are aortic root diseases as well, like aortic aneurysm or dissection, Marfan syndrome, connective tissue disorders, syphilis, hypertension, annular aortic ectasia. So as our first picture, if you all remember, we have seen that there is the LV pressure curve and there is aortic pressure curve. So when there is stenosis or when there is valve closure or stenosis, there is a pressure difference. Now you can see that there is a pressure difference between LV pressures. LV pressures are same, at least we have seen that usme 120 tak aa rahe the, and now they are up to 200. But here the aortic valve pressure or aortic pressures are up to 120. There is a difference of about 80 millimeter. Like LV normally LV pressures are same as aortic pressures. But when there is valve stenosis, then LV pressures are the same or maybe increased because uh, they are pushing against the closed valve. So they are normally increased, but the aorta pressures are decreased. These are because of blockages in the aortic valve. So when there is a normal aortic valve area is 2.5 to 3 centimeters wide, but when it is severe is it becomes less than 1 centimeter square, and in critical it may go up to the zero point 0.7 centimeter square or zero point 0.5 centimeter square. So there is this systolic pressure gradient as you have seen here. So there is a gradient of more than 50 to 100 pressure difference between um, LV and aorta. There is a pressure difference of more than 50 to 100 millimeter. So what is the flow uh, in different valve area? Uh, so I think this is very slightly not at your level. You cannot have to waste your time on this. This is not at your third year level. So just see the pathophysiology of aortic stenosis. When there is chronic LV pressures, chronic LV pressures, pressure overload, it causes LVH. LVH means left ventricular hypertrophy. The muscle mass becomes increased as they have to generate the pressure against the closed valve. So uh, as the pressure increases, the muscle mass increases and causing left ventricular hypertrophy. As you know, okay, in any case when there is increase in pressures, there is increase in the muscle mass. So the LV becomes non-compliant, stiff, it becomes stiff. So it causes increased left ventricular end diastolic pressures. It may be well tolerated for the decades, but when LV fails, कि वो push करके थक गया है, and it fails, then it causes congestive heart failure. But if develops atrial fibrillation, it is poorly tolerated because there is loss of atrial kick, and because of the rapid heart rate, patient may go into the pulmonary edema and hypertension. So aortic stenosis, the natural history and clinical symptoms. Now this is important for at your level. Like when there is aortic stenosis, it may be asymptomatic for many years. But when symptoms develop, uh, then the valve is critically narrowed and LV function deteriorates. Bicuspid valve we usually diagnose at the fifth or sixth decade, and senile as in seventh to eighth decade. But in our population, this is from the Western world, but in our population, we have diagnosed bicuspid valve early, in more early ages, like in 40s, 50s, and in senile as we found it 50 plus or in 60s as well. Don't know because of their dietary habits or what else we found these things very early in our population. So classic symptom triads are in AS, patient will feel angina, they have syncope, they have heart failure, and there are chances of the sudden death. So the natural history, patient may remain asymptomatic. With severe AS, they require close follow-up. We have to see if they develop uh, symptoms. If they are feeling symptoms, then this is the time that they need to have opened their valve. So now this slide is very important at your third year level. This is for the physical findings. When there is severity of AS increases, uh, you feel more and more physical findings. Like when you have to see the carotid pulse, LV apical impulse, and on auscultation you see S4 gallop, systolic ejection click, systolic ejection murmur, peaking of that, and S2. So there is S is mild, carotid pulse is normal, LV apical impulse normal, there is no S4 gallop, there is systolic ejection click, and systolic ejection murmur, which is in early sleep, but no S2. When it becomes moderate, carotid pulse becomes slow rising, and apical impulse heaving. There is S4 gallop, but maybe it may not be present. There is systolic ejection click, and it may not be present in some patients, but the systolic ejection murmur becomes increased after mid-systole. So the systolic murmur become in mid-systole, and S2 becomes normal or single. When there is severe AS, you find more and more physical findings. The carotid pulse becomes parvus adardus. Parvus adardus means it becomes weak and slow. It is weak and slow. You find very low volume and with weak pulse. Alveopical impulse became heaving and sustained, and on auscultation you find S4 gallop. It is because the stiffness of LV valve, and there is no ejection click, but now systolic murmur becomes mid to late, and S2 may be single or paradoxical. Now we are coming to the aortic. I hope you all understand the physical findings, because it is important at your level that you know the cause, the pathophysiology, and the physical findings. No one will ask you about the details or other things rather than these things. Um, uh, so now we are coming to the aortic insufficiency. So aortic insufficiency and the pathophysiology, it is when there is severity. Primary abnormality is what? That when there is left ventricular outflow, volume increases. So regurgitant size becomes increases. There are diastolic pressure gradient, or it depends on heart rate or duration of diastole. So in compensatory mechanism, what happened? LV dilatation and eccentric LVH may be present. So there is increased LV diastolic compliance and peripheral vasodilation. So if we compare it with the aortic stenosis, because in aortic insufficiency or aortic regurgitation MR, same things happen with left ventricular outflow. So when there is aortic stenosis, the LV volume is normal, and wall thickness, there is concentric LVH, as we already know, and LV compliance, we already discussed, it becomes stiff and non-compliant. And when we compare it with left ventricular volume overload, this is the left ventricular volume overload. Because of volume overload, like aortic insufficiency, there is leakage, like LV, which is sending blood to the aorta, because of incomplete closure कि वो बंद नहीं हो पा रहा. when and you all know कि सिस्टली में एलवी जो है वो एओर्टा की तरफ ब्लड भेज रहा है, ठीक है. अब एलवी जब एओर्टा में ब्लड भेज रहा है और डायस्टली में उस वेल्व को क्लोज हो जाना चाहिए, क्योंकि सिस्टली में उसने भेज दिया है, बट बिकॉज ऑफ इनकम्प्लीट क्लोजर क्या हुआ कि सारा एओर्टा से ब्लड वापस एलवी में आ रहा है. उससे क्या हुआ कि के थ्रू जो एलवी में ब्लड वापस आ गया, तो एलवी ने तो अपना ब्लड खाली कर दिया था सिस्टली में, मगर डायस्टली में तो उसके पास ब्लड नहीं आना चाहिए था. वो तो अब मेटल वेव ओपन होगा, वहां से ब्लड आना शुरू होगा. मगर अब जब एओर्टा से भी वापस ब्लड आ रहा है, तो रिजल्ट क्या होगा कि लेफ्ट वेंट्रिकुलर वॉल्यूम ओवरलोड हो जाएगा. तो in the end what happened, the LV becomes dilated. Wall thickness normal or slightly increased is a compensatory mechanism. LV compliance इसमें non compliant हो जाएगा, like वो और ज़्यादा ओपन अप नहीं होगा, एलवी ज्यादा ओपन अप नहीं होगा, बट इन इसमें वो और डायलेट होता जा रहा है ताकि वो वॉल्यूम को अपने अंदर रख सके। डायस्टोलिक प्रेशर एज के अंदर इंक्रीज हो जाएंगे और एओर्टिक रिगर्जिटेशन में स्लाइटली इंक्रीज होंगे या नॉर्मल रहेंगे। सिस्टोलिक प्रेशर, इसमें कि हमने देखा था कि अब एलवी के प्रेशर 200 तक बढ़ जाते हैं ना, तो और इंक्रीज हो जाएंगे, इसमें नॉर्मल होंगे या स्लाइटली इंक्रीज होंगे। इजेक्शन फ्रैक्शन इसमें आपका नॉर्मल रहेगा, इसमें इंक्रीज होगा because it when there is increased volume there is increased pressure and there is increased ejection fraction, like पहले अगर normally हम क्या देखते हैं कि there is 60% ejection fraction, अगर उसके पास वॉल्यूम ज्यादा है और वो ज्यादा बाहर भेजेगा तो ejection fraction will also increase. So, what is the difference? What is the pathophysiology and clinical presentation when there is acute versus chronic AR? When there is acute aortic regurgitation, suddenly LV becomes non-compliant and there is acute pulmonary edema and it needs emergency aortic valve replacement. एकदम से अगर पेशेंट को regurgitation like we have seen in chest trauma के अंदर गए aortic regurgitation, the treatment is aortic valve replacement. But when there is aortic regurgitation, this is the long asymptomatic phase. In this, there is progressive LV dilatation, patient develop dyspnea on exertion, orthopnea, PND, and frequent PVCs may occur on ECGs. So chronic ER signs, these are very, very important. So physical findings, again, I'm repeating, these are more important at your level. So you will be asked for the physical findings, not in detail, but these findings you should all know. There are many aortic regurgitation findings which are also coming when you are doing post-graduation. So these are the widened pulse pressures. The pulse pressure, like there is a difference between the systolic and diastolic pressure, and low diastolic pressures are present here, and because of that, uh, there is widened pulse pressures, and because of the hyperdynamic LV, there are some very interesting signs, and their names are also very interesting. And examiner can ask you about these different names, and you can have to uh, remember all these signs on your tips. उसके लिए रट्टा लगाना पड़े तो भी चलेगा, because you all have to know these hyperdynamic LV signs. First is de Musset sign, Corrigan's pulse, Quincke's pulsation, and Rose's murmur. De Musset sign is what? When you see the patient, when there is a severe AR, patient is nodding his head. He is moving his head, so it is called de Musset sign. Corrigan pulse is the pulse which is you on carotid. If you see the pulse, it's upstroke and going. It's coming. वो एकदम से आपको pulse नजर आएगी, एकदम से it becomes went off. नजर आएगी coming going. It's like Corrigan pulse. And Quicking's pulsation, you see these pulsations on the nail beds. आप nail bed को press करोगे and you feel there is a pinkish pulsation over the nail bed. And Rose's murmur is the murmur which you hear over the femoral artery. Femoral artery पे आपको stolic murmur feel hoga. This is called Drose's murmur. When you press the femoral artery, there is Drose's murmur. We will discuss it when we are doing physical findings practically. This is just for the theory कि आपको नाम at least याद हो और आपको पता हो कि ये क्या signs हैं. Okay. So auscultation में आपको diminished airtone मिलेगा. डिक्रिसेंडो डायस्टोलिक ब्लोइंग मर्मर लेगा। पहले हमने एओर्टिक स्टेनोसिस में क्या था, वहां पे आपको सिस्टोलिक मर्मर मिला था, बट इन दिस यू फील ऑन लेफ्ट स्टर्नल बॉर्डर के ऊपर जो आपका एओर्टिक एरिया है वहां पे आपको डायस्टोलिक मर्मर मिलता है। There is again a question, the Austin Flint murmur. This is the diastolic flow rumble at the apex. ये आपको अगर सीवियर एआर होता है तो आपको मेटल वेव एरिया पे यू फील डायस्टोलिक मर्मर एज वेल, बट इट इज इसका डिफरेंशियल हमेशा कोई ना कोई आपसे पूछेगा, तो दिस इज द डिफरेंशियल इज मेटल स्टेनोसिस, क्योंकि एपिकल एरिया पे डायस्टोलिक मर्मर आपको मेटास्टिनोसिस में मिलता है, मगर बिकॉज ऑफ सीवियर एआर आपका एआर जेट जो है वो आपके मेटल फिलिंग के ऊपर या मेटल वेल्व के ऊपर उसके प्रेशर दे रहा होता है, जिसकी वजह से वहां पर आपको ये फील होता है। सो हमारे डायग्नोस्टिक टेस्ट कौन कौन से आते हैं एओर्टिक स्टेनोसिस में? अगर आप ईकेजी या ईसीजी कराते हैं तो नॉर्मल साइनस रिदम होता है, आपको एलवीएच विद स्ट्रेन मिलता है, और आपको लेफ्ट एट्रियल एनलार्जमेंट मिलती है ऑफ लेफ्ट एंटीरियर, आपको लेफ्ट एक्सिस डेविएशन मिलती है। एक्सरे नॉर्मल मिल सकता है। ऑन 2D echo you can find the aortic cusp are thickened, calcified, decrease in mobility. Assessment of LVH and LV, and there may be concomitant MR or AR, and you can find Doppler assessment on the basis of echocardiography. You can find aortic gradient. इन अर्ली डेज के सिर्फ कैथ ही होता था, जिसके ऊपर आप जो हमने आपको शुरू में पिक्चर दिखाई थी उसमें वो हम लोगों ने कैथ के थ्रू ही कैथेटर से हमने प्रेशर्स लिए थे, मगर अब एको इज द गोल्ड स्टैंडर्ड इन विच वी कैन सी द प्लेनिमेट्री एरोटिक एरिया भी हम देख सकते हैं, और हम उसमें प्रेशर ग्रेडियंट भी ले सकते हैं। इन एरोटिक रिगर्जिटेशन ECG there is LVH but without strain, एक्सरे में आपको chronic AR मिलेगा और वो शो करेगा chronic bovinum. Chronic bovinum there is massive enlargement of the heart, आपको because of chronic AR आपको massive enlargement of the heart मिलेगी, और pulmonary edema with normal heart size भी मिल सकता है जब acute aortic regurgitation होता है। 2D echo में आपको aortic valve आपको दोनों ही के अंदर stenosis और regurgitation में आप valve को assess कर सकते हैं, valve की pathology देख सकते हैं। You can assess the LV function like ejection fraction or LV dilatation or LV hypertrophy on echocardiography. There is Doppler severity, आप severity of regurgitant chair देख सकते हैं on the basis color डाल के, और there are multiple calculatory methods on the echo. Now we can assess the uh, on echocardiography we can assess the stenosis and regurgitation as well. So in now coming to the treatment, so there for the aortic stenosis and regurgitation, initially there was only the treatment was aortic valve replacement, but now there is emerging a new method of balloon aortic valvoplasty. Uh, so we can do this is like minimally invasive. We are not opening the chest, it's like angiography, we are going through the valve and opening valve, और इसमें हम आजकल टावी एक न्यू मोडेलिटी आई हुई है जिसमें हम एओर्टिक वेल्व ही एंजियोग्राफी के थ्रू हम एओर्टिक वेल्व ही वहां पे रिप्लेस कर देते हैं, लाइक उस उन पेशेंट्स के अंदर जिनको एओर्टिक स्टेनोसिस, नॉट इन एओर्टिक regurgitation but in aortic stenosis in patients like in congenital haze, predominant commissural fusion, ये valvoplasty की हम बात कर रहे हैं, या AVR से अगर हमने we have to bridge it, or there is moderate severe heart failure and cardiogenic shock. So in these conditions, we can do valvoplasty, but now there is a new method of TAVI is coming, emerging as well. So for the aortic stenosis, aortic valve, there are aortic valve surgery. First we assess, and if this is the both are going into the severe and patients are symptomatic, then aortic valve surgery is the treatment of choice. Okay, thank you guys.